getting correct rhythms. Is that okay? All right. It's also a crucial tool in identifying abnormalities. So we can identify an MI. You can identify an acute coronary syndrome going on in that heart from your ECG. And how would you see this? You see, so we have the ST elevated myocardial infarction, not what you call STEMI, or you have non-STEMI. ST segment elevation is one J point. So can you see ST? You see that ST point on my screen? You can see the P wave. Let's identify them. You have the QRS complex, yes, and then you have the T wave, which is the other structure that looks like an ant hill. While in between this R wave, this long guy, and the other ant hill is the ST segment. The J point is the base of the R, right? That J point is the base of the R. If it rises above the isoelectric line, you're looking at an elevation, but there's a measurement for it. If it depresses below the isoelectric line, you're looking at an ST depression, and there's a measurement for it. Ladies and gentlemen, let's not enter that temptation. We'll spend many hours here. Is that okay? But with myocardial infarction, we can truly identify an MI, a heart attack, with your ECG. You can identify electrolyte imbalances. You can identify other cardiac pericarditis. One cardiologist was showing me how to identify pericarditis. I was like, boy, electrical imbalances. He was saying, you see when the P wave does this. I'm like, wow. So cardiologists will tell you more stories. Right now, let's stay basic. Is that okay? Let's stay at the basic level. So everybody, the ECG structure has waves on it. Each wave depicts an activity in the heart. And I just thought to use this table to explain. We have a guy called the P wave. That P wave refers to atrial depolarization. I like to use the word depolarization synonymous with a demand, atrial demand. A demand was made, and an excitement occurred at the atrium, okay? The SA node, AV node, excitement at this myocardial cells. And then that impulse being generated is travels from the SA node to the AV node. The P wave is the signature of atrial activity. Is that okay? Then you have the QRS complex. The QRS complex is a signature of ventricular demand, right? Ventricular repolarization. Then you have something called the PR interval, and you can see that on my screen as well. The PR interval is the time that it took for the impulse to travel from the SA node all the way to the ventricle, from the atrium to the ventricle. How long did it take? Right, there's a timing, there's a measurement for it. It's 3 to 5 small boxes. The small boxes are these smaller, tiny, teeny-weeny boxes in the graph, in the ECG strip. Then the bolder red lines are what we refer to as big boxes. So normal timing is either 3 small boxes or 1 big box as a PR interval. You can tell if there's a heart block, if there's an AV block, by virtue of the distance, that the time travel distance in the PR interval. So once you have an elongated PR interval, you'll be able to tell, oh, there's a block here, but you need to be able to identify what kind of block it is. ECG, again, no temptations allowed this afternoon. Everybody? All right, then the ST segment refers to early repolarization, where ending with the T wave, which depicts ventricular resting phase, ventricular rest. Okay, so that's the resting phase of the cardiac cycle. So we refer to it as ventricular repolarization. Okay, that's what the T wave depicts. And then the isoelectric line, the flat line that you see, shows that there is no activity going on at that moment. Ladies and gentlemen, this graph depicts one cardiac cycle, not circle, cycle. See why that? Cycle, one cardiac cycle. Is that okay? Right. Your reading, your identification of what is wrong with this patient greatly depends on your familiarity with the structure of the ECG. Are we together? Like I said, this is very basic. I know our time is running out. I'm very conscious of that, but let's take a look. So with this ECG interpretation, I need to be able to identify life-threatening rhythms and be able to act fast. With asystole, which we identified earlier, we have a flat line. What this means is that there's no, in fact, my Purkinje boys are not even working. They're not attempting, the generator is not on, no generator, no power source is attempting to power the heart. And this is nearly fatal because, of course, we can have asystole and intervene, and then we can have we can have a return of some form of rhythm. So what you find is a flat line, and asystole is not shockable because there's nothing to shock. I told you that the energy that the defibrillator is sending is to people who are already there saying, we're trying, but we're not able to power this, our household. And says, okay, take power. Or go at the top, take power. But now nobody's even making any attempt. Once the energy goes there, there's nobody is going to meet. There's no generator that is on that will pick the electrical current you're sending. That's why asystole is referred to as non-shockable. Is that okay? But the ventricular fibrillation, on the other hand, like I explained, my Pockenger boys are saying, everybody, Mona, try, everybody, push your energy, let's try. We can do this. In Nigeria, we can move Nigeria forward. Everybody put your hand on the deck. Right, everybody, every ventricular fiber, every Pockenger fiber making attempt to, so what you have is chaos. That's shockable because there's some rhythm activity ongoing in that chest. In that heart, rather. So you can shock. That's why it is considered shockable. Pulseless ventricular tachycardia is also shockable because I have tachycardia. I'll have a very fast heart rate, but in real life, the heart is actually not giving off that beat. It is not real in itself, but it is an activity. So it's shockable. I'm able to send impulse to it and then help reverse that activity ongoing. Is that okay? With bradycardia, you have poor perfusion, and then you may need to pace this patient. So for ACLS, we have different protocols for treating bradycardia and tachycardia. Is that okay? We'll talk. I'm sure we don't have so much time to enter into those things, but let's move away from here. Why I brought this up is that you can have one quick look at this patient's monitor and see what exactly is. I'm not going to ask you to identify the activity because it's a bit blurry on the screen, even though I can enlarge it, yes, but let's move away from here. With the STEMI, STEMI meaning ST, elevated myocardial infarction, as you find in acute coronary syndrome. You find ST segment is altered. Is that okay? Most times elevated, and then you have to look at what leads are carrying that information so you can determine if you have a heart attack in this regard. With this interpretation, ladies and gentlemen, you must know what to do. There are 10 steps, actually basic 5 steps. You must be able to identify the heart rate. The first simple method will be to count all the airways. I have 10 airways showing up. So 1, 2, 3, 4, 5, 7, 8, 10. 9, 10, and then I multiply by 10. I say, oh, the heart rate here is 100. Or I have 7 airways, and I say, oh, okay, 7 times 10, 70. The heart rate here is 70. That's the first basic method. There's a second method that allows you to count the big boxes and divide how many big boxes you can see. Divide 300 by how many big boxes you can see. Right, and then you must be able to identify the heart rhythm. Is this pattern that I am seeing, is it the same in every cardiac cycle? I don't like it, yes, but is it the same? Are you with me? Is it the same? What I am seeing, it happened in cardiac cycle 1, so it's happening in cardiac cycle 2. So is it the same? Oh, yes, it's the same. It means that I have an abnormal heart rhythm, but yes, it's regular. Or is everybody chaotic? This one did as he wanted. The other cardiac cycle looks different. This one, everything is not just not looking the same. Then you can say it is irregular. And you have to look at atrial activity and ventricular activity for you to be able to determine this. Then you want to assess your P waves. The P waves there, is it present? Is it upright? Is it looking good? Is there a P wave for every QRS? And are they all looking the same? So assess your P waves. Then your PR interval, is it too short or is it too long? Right, that's what you're doing with PR interval. And then your QRS complexes, how do they look? Is it smaller than 3 small boxes, or is it a wide QRS complex I am dealing with? You must learn to determine the origin of every ECG strip you see. Is it a sinus rhythm? Is it an atrial rhythm? Or is it a ventricular rhythm? Or is it an unknown rhythm? It's coming from somewhere we don't know where it is. Is it an unknown rhythm? Is that okay? For the advanced steps, you are looking at your ST segment. You're looking at your ST segment. You're looking at the T wave. How high or how low is that T wave? You're comparing all that you are seeing with your patient's clinical condition. Do you realize what we learned in PEA? Pulseless electrical activity. It shows that there's an activity. No, this one there's an activity. Just leave the patient. But you're not assessing the patient to see that what you saw is different from what is actually happening with the patient. Never take an ECG reading and conclude with it. Always assess what you see. with the human being that owns that assessment you are seeing, right? So it will help you know how to respond. Are we together? Then always make sure you are able to draw a conclusion, but you may also have to get expert consultation. You are never alone, people. I like the fact that you're up there and everybody's happy that you're on duty each time that you're on duty, because they know that emergency run out is going to be smooth and beautiful. But you sometimes need to have expert consultations around you to be sure that we're doing the needful. All right, so that's the best way I can handle all the steps, but please note that basic steps are the first 6 that I just mentioned. Know the heart rate. Is it fast? Is it slow? Is it normal? Know the rhythm. Is it regular or irregular? Know the P waves. Are they present or are they absent, and are they looking okay? Know the PR interval. Identify whether it is long or short. That will tell you if there's a heart block or not. Assess ventricular rhythm, QRS. Ask, is it wide? Is it narrow? How's it going? And then who is commanding this heart? Is that okay? Those are the basic steps. Let's move away from ECG to a bit. Okay, so yes, we have answered questions in our puzzles. Pulseless ventricular tachycardia, and yes, it is shockable. Asystole, yes, is non-shockable, and I've explained why. Ventricular fibrillation is shockable, and then pulseless electrical activity. In this regard here, we have an atrial flutter showing up on our screen, and yes, it is non-shockable. Everybody say yes. All right, so let's say that we have intervened. Now that we have intervened, we got our patient back. Right, so let's look at what our care will be. And I'm using the ACLS protocol as recommended by the American Heart Association. Post-resuscitation care requires that you're stabilizing this patient's vital signs. What are the vital signs? I'm looking at this patient's blood pressure. I'm looking at this patient's pulse rate. I'm looking at this patient's respiratory rate. I'm looking at this patient's temperature. Right. I'm looking at this patient's SpO2. What am I finding? What am I having? Hemodynamics, am I good? What can I do to stabilize? Do I need to rehydrate? Okay, can we put up fluid? Especially with ACLS, you must have had hypovolemia being treated and being handled, right? How am I protecting the airway? Have I intubated? Am I able to support this patient's ventilation with intermittent breathing, or with rescue breath? That's 1 breath every 6 seconds. Or have I connected this patient to a ventilator? What am I doing that is improving this patient's respiratory and tissue perfusion status? And then with my ECG and blood gases, what's my ECG saying to me? What is the state of the heart? How is the heart feeling? How is the heart coping? Is the heart happy? Is the heart able to function the best way that it wants to? What is the blood work saying? What kind of gases? Do I have acidosis? Do I have toxins? What am I seeing? What am I experiencing? Or what's this patient rather experiencing? And then, can I prevent organ failure? Yes. And all my interventions is aimed at ensuring that I do not have the heart go down completely. I do not have blood vessels collapse completely. I do not have the respiratory tract go down completely. I do not have the lungs shut down on me. I am working to make sure that this patient is up and running, even if I have to give this patient intensive support. The family is going to be out there worrying. I am the middleman. Am I doing well to communicate what is happening? Am I able to support them in any way? ACLS has one video where one doctor came and said, I'm sorry, your father didn't make it, and this kind of things happen, you know, and let me go back and wait and attend to people who are waiting for me. Like, seriously? We must learn to be in their shoes. I know it's a lot. Honestly, it's a lot. You have to deal with that patient indoors, and you have to come out and deal with the family out there, but we have capacity. Tell yourself, I have capacity. We are built for it, especially if you are that nurse that came into this profession with the passion for it. You are built for it. You have what it takes, okay? And then you must learn to document. Not whatever is not documented was not done. Document the event, document your actions, document your activity, document the feedback. What was the outcome of your action? What did you get? I needed to push up this pulse rate. I needed to push down this temperature. What was that intervention? What was your reason for doing it? And what was your outcome? Then we must learn to debrief. I'll talk about debriefing shortly. Debriefing here, let me just throw it in, is where the team comes together and says, this is what we have done. This patient came in like this. We did this first. We did this next. We did this next. We did this next. We had a setback here. We're able to come back and we did this next. What did we not do right for next time? What did we do well that we're happy about and we can make it a law and a standard in our time, right? Or in our environment. So this is you building protocol and policies based on your learnings from an event. This is crucial to your next event, because if you don't learn from the past, you can't measure your performance. Is that okay? So it's important that we harness this skill as part of our interventions. Let's talk about rapidly transferring our patients. Let's take it that you are in a facility where you are able to give BLS and ACLS support, okay? Basic and advanced life support to this patient, or you intervened in some way. You need to stabilize this patient before you transfer. So make sure that you have those numbers looking okay. So this patient is fine. The statistics, the biostatistics of this patient are looking okay and good enough for transfer. You don't want to be transferring the patient that has an SpO2 of 51. You say, let's just transfer. No, you're not helping anybody with doing that. You and the patient itself, you'll be stuck in the middle of the road and you have a lot to explain. So make sure that that patient is stabilized before you do a transfer. Make sure the airway is secure. You can keep bagging. If anything, if there's any compromise in that airway, you can keep fighting till you get to where you are headed. Make sure you have IV access and it is functioning. Not that as teacher I say, let's just manage. Let it just be doing. It's thrombose, veins are thrombose, let's just try. No. That's why I said best practices. What is it that we actually practice? What are these things that we do? That just look at it and say nobody's going to ask you, or because patients do not know, patients are obviously semi-conscious or unconscious. You just do it the way you feel like doing it. Nobody's watching you. You know there's somebody watching you. Your heart is watching you. God is watching. I'm just saying, can we just do what's ideal? Can we try? And even if you don't have everything at your disposal and you are improvising, can you make best use of that improvisation that you're doing? All right. And then equipments. Do we have capacity? So this doesn't speak to us, maybe except if you are a nurse who is a facility owner, but this speaks to facility owners. What do we have in our facilities? Are we able to have monitoring equipment, continuous monitoring equipment that will help us give a quick overview of our patients and make our interventions faster and smarter? Go to some huge, mega hospitals in Nigeria today. Enter the emergency room. You'll be wowed. You'll be shocked. I don't know if it's wow or shocked. Which one is correct? Right, but it's such a dilapidated state. We only have a few private facilities coming up at their best with these things. And I'm proud of everyone who is doing that to change that narrative, who is working hard to change the narrative in our healthcare space today. And for nurses, if you are in a place that has every equipment, don't feel irritated at the fact they always want you to document. They always want you to do this. Must I do this? Is it not somebody's work? Know everything. In my facility where I work, away from this English I'm speaking to you here, I work somewhere. In that facility, people, I can attend to a patient start to finish, except maybe in the lab where I cannot operate some of their machines. But hey, with pride, I can take that patient, start off my basic responsibility, get to where I need to do phlebotomy, get to where I need to do an ECG, get to where I need to do even basic scans, just that I will not be excellent in reading, but I can see echo textures and say, oh, this is something here. Spread your wings. You're not doing it for somebody, you're doing it for you. Right, and then prepare to document. Let's move fast and make sure that you do well to reassure family members. With reassuring family members, you're using what's called the S-bar. With the S-bar, you're looking at the situation around that patient. What's that background? What has happened? Where are you and where are you heading? What has, in all the checks that we have done, in all the interventions that we have done, what is your rough assessment? Okay, I think the prognosis is okay, or I think we're not doing very well, and I want to recommend we do this. This is you having to communicate, and you have to make sure that your communication does not have promises. Don't ever promise them and say, don't worry, madam, your son will come back. Just keep praying. You don't have to kabash very well. You don't have to call your imam or your people. No, I'm not saying don't pray. I am a prayer person. Yes, I'm not saying don't pray. There's a thin line between actual doing, actual action, and praying. Right. Do what is needful. Is that okay? All right. Okay, we'll take our questions after. Okay, so let's run fast, where I think I have just a few minutes more. Okay. So let's run fast and see what are the new innovations now. What are the new innovations with emergency care? I just listed them here. I'll show them to you one after the other. Okay. We have AI and telemedicine that helps us with triage. There are some wearable vital sign monitors now that patients can wear either in facility or at home. I attended the cardiovascular conference some time ago, and I was impressed to know that you can do a stress ECG with a wearable device on the patient, allow them to walk around, and then you're able to, on a larger monitor, see the electrical activity of that heart. That was quite impressive. And it's here in Abuja. So I'm saying, yes, we have so much happening now. We also have the use of AI and telemedicine. I mentioned that. So AI here, having a patient being remotely seen. Patient is another location. I am in one location. I can put that patient up and say, okay, put up your device, look at this app, turn it on, put this camera on you, talk to me, tell me what you're feeling, show me where you have the swelling, show me where you have the pain, and I'm able to speak to that patient. Or we have AIs imputed into apps that can speak to patients and say, okay, I recommend take this, I recommend do this, I recommend stretch this way, I recommend call your healthcare provider. Okay, there are limits to what AI can do, and I'm sure there are regulatory protocols of how we should follow what AI says. Is that okay? And then the wearable vital sign monitors, and then you have mechanical CPR devices. I'll talk about that shortly. Point of care diagnostics. You have simulation-based training for nurses. Someone shared a video with me of a facility. I don't know if it was in Maryland, in the USA. It's a whole ward. Everybody, I don't know who has come across that video. People, it's a whole ward that has mannequins. I thought they were people. Mannequins that had different conditions. Nurses were made to go into those rooms and treat those mannequins like, depending on the condition on the mannequin you go to treat, yeah? Treat that mannequin like it was human. I liked it because I said to myself, this will allow us to have hands-on before we get into actual field practice. And even if I knew it before, are there newer protocols, and can I go and practice my protocol before I actually practice it on a human to avoid the errors and poor management as we see it in a lot of cases. And then we have drones that are able to deliver medication aid or medication resource to difficult to reach areas, right? So here's AI and telemedicine, someone somewhere, and then we can speak and we can talk about what person is feeling and give recommendations. So it enables real-time assessments. I'm able to assess that patient instantly. I'm not there, but I'm able to, say briefly what is happening with this patient and then give recommendations. Take a look at wearable vital sign monitors. They're smart, they're cute, right? They can wear them, some on the arm, some at the chest level, and then you can view a larger monitor that displays what this patient is going through, experiencing. So you're able to, you can see blood pressures, you can see the patient's data, then it alerts us, it tells us, when to act and when and what to do in most cases. Then you have CPR devices. I'm sure you've seen these things before. So you have mechanical CPR devices. I was trying to see if I can dig up where it was actually used, but I think that video was restricted. I saw one on a particular hospital site, but it was restricted, so I couldn't bring it up or pick up that video to share. But this is a new innovation that allows for chest compressions, and it doubles as a device. The one I saw actually doubles as a device that can strap that patient onto a patient stretcher and then move that patient carefully to a next location, especially if you have gridlocks, you have obstructions, either road traffic obstructions or something that makes it difficult to assess patient. But these devices are able to give compressions at the rate, the required rate and the depth, ensuring that at least some activity, some resuscitation activity is ongoing before we get to this patient physically. So you have CPR devices that you can use. While then it also allows us to focus on other things. Like I can be doing other things while this CPR device is giving compressions for this patient for me. They have point of care diagnostics, the simple things that we use, everyday things that we use, the glucometers for our urine testing, for our glucose testing, the urine strips, you have pregnancy test strips. These are simple cholesterol tests. These are simple, instant devices that can give you instant assessment of your patient, instant results of your patient. You can do it bedside, you can do it at home, but it gives you a broader insight to what that patient is experiencing. And I advise every nurse to know how to use as many devices that are around, as many that you can lay your hands on. Practice, and if you have one in your facility, you're not familiar with it, go and study about it, go and read about it, go and watch how to utilize it, so that on the day that you have to use it, you are not lost and ineffective with treating your patient. Okay, so simulation-based training for nurses, I mentioned, where you have mannequins and we can practice many things. You can practice intubations, you can practice ECGs, you can practice trauma care. You can practice so much, right? With one mannequin, so depending on how that mannequin is designed. But again, we're sure that we don't have patient safety risks here because it's a mannequin. Right, it's not real human, but it behaves and is made to act like a human. Practice makes perfect. Everybody, if you agree, say yes. The drones can help to deliver emergency resource depending on the area where it is needed. If it's a difficult to reach or hard to reach area, especially in areas where there's war and areas where there are disasters that has occurred and your resources need to go there on time, you can use these drones to deliver. So these are innovations that are up there and are useful for us. Let's go to the last part of our conversation today, and I'll do quick. We do good or do well to round up on time. Let's do an overview of emergency care systems, and I'm going to be focusing on Nigeria. However, let's look at the ideal setup, the emergency care setup for us. So, like I said, we're always a part of a team. We're always a major part of a team. We're not alone. We're usually not alone. But here's where to start. Number one, in the environment where you work, the community that lives there, what do they know? The community that lives around, what do they know? What kind of pre-hospital care setting or setup is around you? So let's take the US, for instance. As much as I do not live there, I have taken a little time to study how they work. For them, they have a lot of community education that goes on. They are able to create CPR awareness. They're able to create protocols for different communities. In fact, different states or different no, they're not called provinces. Different states have their protocols, okay, and who to call in case of an emergency. They have the broader 911 National Emergency Call line, but they have taught their community how to behave, how to respond in case of emergency, at least at a basic level. So they're not rushing in a patient, even if they had to call an ambulance. They are taught that you can do something before the ambulance comes to you. And calling the national emergency helps you have advanced care, advanced professional kind of help come to you. Okay, and that's where the pre-hospital care comes into play. And then there's also in your emergency room now, your facility, there's always a strategic layout, how it should look, how your environment should look, so that you're able to triage neatly and everybody knows what kind of patients are on this side, what kind of patients are on that side, what kind of patients are on this side. Like I said, with the triaging, you have the red zones. The red zones have very critically ill patients. You have the yellow zones, life-threatening conditions. You have the green zones with minor injuries. There's also a black zone where patients are considered dead, right? So this is you having to know what these zones are and how to manage patients or triage patients into these zones. Equipment and supplies need to be adequate. This team is usually multidisciplinary and they are skilled. There's nobody who says, I don't know how to do it so that you'll be on a team. They'll probably attach you to a mentor. You learn and relearn until you can confidently say, I'm a part of this team. And then there are protocols and guidelines. The AHA has protocols. The American Safety and Health Institute has protocols. Several, the acute stroke care, there's a name for the stroke team. They also have protocols. Whatever that protocol is, they are utilized depending on the condition of that patient. And our communication system, how do we communicate? Nurse Gloria, help me call Dr. Obi now. There's an emergency here. Don't mind me. How do we communicate? Truly. How do that patient in bed 4 that has heart attack. that had that attack yesterday. Come on now. How do you communicate? How do you communicate? Sorry that I'm shouting. Right. We need to be able to go back home, go back to your facility and say, guys, let's reorder this thing. The ideal is that you must have some ways to communicate. Either you're communicating with devices or you're communicating with, of course, the devices usually at play, or you're sending messages, you're paging or you're mailing. There has to be a way to communicate, or you use codes to communicate, even if you have to communicate verbally. In some facilities, you have buttons. Just press the button, that communication goes on. Everybody who hears that sound knows what it is, and they know where they are headed. So we're not there yet. I'm not talking about Nigeria. I'm saying globally, there are different system structures and strategies in place with communication. In your environment here, try and ask yourself, how are we doing this and what can be better? And then continuous education. This is why I give it up to the EHA Academy with this webinar. Training and retraining, continuous learning. You never know everything. You don't know everything. I'm sharing knowledge today. It took me, I sat down 3 whole days. Like everybody's wondering, what are you doing? Like I need to put my slides together and I need to know everything I am saying. 3 whole days to learn. You learn and relearn, right? You have to come up stronger each time you come out. Don't be the old you. Don't be in the 1940s and say, that's how they used to do it. Oh, nobody does anything the way you used to. No, the trend is changing and you need to change along with it. Psychological and physical safety of all the staff, everybody in the emergency room, there must be some way that we are protected. Psychologically, maybe as a result of all the trauma we've seen, patients, the things we see patients go through, sometimes we lose patients and we feel, I'm not doing this thing again. I beg you. With everything we did, we still lost this patient. Sometimes some of us have grown so cold that death is no longer a big deal to us. We must be able to protect our minds. We must be able to protect our mental health. There must be structures in place that protect us psychologically and physically. And then operational capacity 24/7 must be in place. Do I have light? Do I have water? Do I have every resource I need? When my resource is running out, who is bringing it for me? Who is checking on how my equipments are doing? People, things need to work in an ideal circumstance. It needs to work, okay? What are strategies for staying effective in an emergency? 1, stay calm. If you have a neighbor, look at a neighbor, stay calm. If you don't have a neighbor, tell yourself, stay calm, stay focused, right? You must have emotional control. That okay? Patient is shouting, you are shouting, you're not helping anybody. So stay calm. Pretend. I always say to my students each time we're in class, you are permitted to be afraid, ladies and gentlemen. What you are not permitted to do is to show your fear. On no account should that fear come anyway. Are we together? Right. And then learn to communicate clearly. There's something called closed loop communication within teams. I'm using quotes, but we're saying clearly. I say, give 1 milligram of epinephrine. And the person who I spoke to answers me because that person knows, oh, I've already assigned that task to that person. And I say, oh, Nurse Kelvin, give 1 milligram of epinephrine. Nurse Kelvin should be able to say to me, 1 milligram of epinephrine drawn. And at the point of giving 1 milligram of epinephrine, given. I should not assume and say, I don't know if she gave. Nurse Kelvin, have you given that thing? Because Nurse Kelvin is beefing me. He's not talking to me and we're doing resuscitation together. No, it doesn't work like that. Be enemies outside. But if you are together in a resuscitation room, you must work professionally. Leave your beef outside. Finish that job. When that patient is done, when you're done with the patient, either you resuscitated, your resuscitation attempt successful or unsuccessful, and you are coming out of the room. The moment you come out of the room, be enemies back. Right, but I'm saying that we must learn to communicate and communicate clearly, okay? Call each other, speak to each other professionally and respectfully. Each time an instruction is given, make sure that you confirm. Then your actions must be prioritized. ABC always comes first. Airway, breathing, circulation, always first. Don't say, wait, let me go and see if I can get that drug before we start. Oh, no. Start with your ABCs. You don't need medications for that. You don't need devices for that. Take a look at that patient, see what you can find and move. Is that okay? Then regular drills will also help. Regular drills will help. And then your protocols. What are the protocols that are guiding you? And I said before, you must learn to debrief. I've already explained debriefing. Everybody come together, ask yourself, what did we do well? What did we not do well? Welcome to Nigeria. Everybody tell anybody, say welcome to Nigeria. Okay, everybody, welcome to Nigeria. We have challenges in this part of the world, I must confess. Challenges with how best Oh, I put a triad layout. Oh, I didn't see this. Nice. Look at what I was saying. The red zones, the yellow zones, and the green zones. Okay, so you may want to munch this screen something just to keep this with you, right? And then you have isolation rooms for infectious diseases. What are the gaps in the Nigerian emergency system? One, there's poor awareness on CPR. Very poor. Very, very poor. And I'm sorry to say, even in the healthcare space, poor assessment of CPR. And then our emergency response is also nearly zero. It's not at its best, to be honest. We're not, we don't have the best systems yet. We're not where we used to be. There's 112. Everybody say yes. There's 112. And I was doing a brief assessment of 112 some time ago. And somebody said, I've called 112 before. And it was a fire incident. And 112, within minutes, the fire service was there. And I said, oh, beautiful. Another person said, oh, there was an incident and we called, I think the police, or I can't remember, road safety. The second one was road safety. They said they called road safety. These responses came because the structures are in place. Talk to me about what medical structure is in place to respond to medical emergencies. Right. I'm glad that we have private medical emergency services coming up now. And I'll share, we have them coming up. We have them coming up. Ambulance services are coming up. Critical care managers are coming up. And they're even with Keke. I saw a service that uses Keke to get to remote areas and quickly pick that patient. And the person who is coming with the Keke knows at least a bit of what to do, help to, improve that patient's chances of survival, help to give first aid, basic interventions, and move to a facility. Me, I have a question for all of us in this room. Let's assume ambulance service guys do the needful, and that system comes into play, that everybody who is paramedic is up and running. We have ambulance services, and in 3 minutes or in 12 minutes, an emergency has reached you in the hospital. You that is in the hospital, do we know what to do? Do we have what it takes to respond? So it's a two-way thing. Outside our facilities, outside us, and then us. I'd like us to upscale our skills, everybody. That's my message for, I don't know who I'm talking to today. If you have not learned anything new in the last 6 months, you are playing. I saw you are playing. Make sure that you know something. You know how to do something extra from the regular injection. I give injection, check I'm done. I do vital sign, I do blood pressure, check I'm done. There are many things out there we need to know how to do. Please upscale your skill. Are we good? And then we also have poorly equipped emergency facilities. That's what I'm saying. And then shortage of trained personnel. Okay, I've said that before. And limited access to defibrillators. I had the privilege of meeting someone. I don't know if I should mention, but there's an association, a society of some specialists that are coming together that are trying to see how they can do public access defibrillators. And I've been applauding that initiative. And I'm hoping that we can support it. We can learn that. But some of you that do other businesses and have money, sponsor one defibrillator in ShopRite. Not ShopRite, sorry. Sponsor one defibrillator in a public space. It can be Garki Market. It can be Wuse Market. Sponsor the purchase of one defibrillator. Let's install it, and let's teach people around there how to use it. You are saving a life by doing that. Let's not look at it and say, we don't even have defibrillators. I went to teach ACLS in a hospital one day. People, they don't have defibrillators. I said, where's your AED? Bring your AED so that I can get it family. I said, I'm not sure we had AED. I don't have AED here. I also had the privilege of going to Niger State one day, Shiroro local government, and there was an incident that day. That incident was very painful because there was an ambush on armed officers, and an explosion rocked their van. Some of these armed officers were blown to pieces. Some had multiple fractures. So the ones that they could put together, they put them in their van and they were rushing them, man down, man down, man down. I was about to enter into that facility to go and teach ACLS, and I saw practical. Have I mentioned from the beginning of this training that I like emergency? Okay, so don't shout. You can relate, right? So I saw practical. I was like, yeah, see what's happening. The moment one of the staff came and said, please, we need help. Is there anybody that can help? All of us that were instructors just walked in. I was like, yes, we put on our gloves, got ready. I asked them that no, it was not even me that asked. It was another instructor that said, do you guys have a manual defibrillator here? They said, oh, yes, we have. Guess who went to bring it? The MD. The MD went into his office. Don't laugh. If you laugh, I will know that you're laughing. The MD went into his office, went and brought out a nicely packaged carton. Came and he has opened the carton. So the carton is not open. It's not now, he's opening it. That's been open before. So they've seen the device, yeah? But that device is in the carton. He brought out manual defibrillator. Cha-cha. Do you know cha-cha? still strapped in his nylon, everything looking sweet and beautiful. I was like, okay. So when you have emergency, what does happen? Say, the device is here, the device is here, but it's how to use it. They're not alone, no. They are not alone. There are a billion other facilities that invest in buying devices, the buying equipment, but are unable to use what they have. Why? Knowledge gap. Don't be that person. Upscale your skill. I'm saying that again. Right. Make sure that I'm talking to policymakers, as many of them that can hear me today. We need to improve our access to emergency equipment, emergency devices. We need to improve our access to defibrillators. Defibrillators are not big deals. In the US, some doctors work with, and doctors and nurses, in fact, instructors work with defibrillators in their cars. They drive with it so that in case of any emergency, they can help and help effectively. Right. Weak referral and ambulance systems are major crops in our, major gap in our emergency system. What can we do? Right. So I met this lady. She's the CEO of Emergency Response Africa. No, I met her. I just saw her content online. I mean her work online. That's what I mean. Her name is Folake. Folake owns emergency response, and is how I said uses motorbikes as pre-hospital care service transport system, and uses keke so that remote areas or places that are hard to reach or places that will be difficult to get a car and ambulance and keke come, someone trained person follow. This is ambulance, this is first aid kit, this is your resuscitation requirement resource. Quickly go to so place. And they're doing well. But she said something. She says emergency medical services are a crucial but often overlooked part of Africa's healthcare system. They are budgeting for many things. But in Nigeria and in Africa generally, hardly do you find somebody who is intentional. And I think this speaks to our Ministry of Health. We need to be intentional about improving pre-hospital care, but even strengthening the hospital facilities themselves is also important. We need to have funding. We need to have access to training. Healthcare providers must be trained and adequately trained when it comes to delivering emergency care, especially pre-hospital or even in-hospital care. So what can be done? Improve our community CPR programs. Everybody who is in this room, I want to throw a challenge to you today. Before the week runs out, where are we? This is the last day of the month of June. Okay, so let me give you more space before the month of July runs out. And I'm going to be speaking to the EHA academic team. I'd like you to follow up as part of our follow-up on this webinar today. Everybody, gather your neighbors, your family members, and your neighbors. Teach them one emergency. Teach them something about emergencies. If it's CPR, you want to teach them. If it's bleeding, you want to teach them. If it is how to identify a heart attack, you want to teach them. You are not novices, you are professionals. Whatever I said, I told you today that everything I will say, you already know. We just want to structure it or refresh our memories or tickle our minds on knowledge. Gather people around you. Teach them something about one form of emergency. Look at what are they at risk for in your environment. Some people, they're at risk for gastrointestinal infection. So you probably have a lot of children come down with diarrhea, and then they become dehydrated, and then you're speaking English. Teach them what to do. Teach them health, sanitation. Teach them how to deal with their waters. Teach them how to recognize emergencies. My husband showed me a video of somebody who was preaching today. And he was preaching, and then he was preaching, and everybody said, yeah, yeah. And he was saying, oh my God, and yeah. And then he went down on his knees, and everybody was still saying, yeah. And he too was saying, yeah. And the next thing he lied down, and they were expecting yeah to happen. They thought it was part of the preaching. Guy was in arrest, and that was it. Then it was much later, the whole hall went quiet, and somebody had to run to him and shake him, pastor. Guy was gone. In a lot of clients, they'll start kabashing. The needful needs to be done. Teach your community something. In your honor, let it be that somebody remembered what you said. A friend of mine reached me from the UK and said, Dupsy, thank you for CPR. Thank you for CPR. My neighbor in the middle of the night, 2 a.m., they said something happened, something. I just remembered it and I went straight. And she did CPR, and today that person is alive to come back and say thank you. Teach your community something. Is that okay? To policymakers, to our government, we need to upscale our 112. A national emergency number is a 3-digit number, it's 112. We need to improve medical emergency capacity. And I want to say to everybody here, be a volunteer when that thing comes. Because they're saying, who will we use? Be a volunteer, be a volunteer. Offer your time to work from so time. So if you live in Kubwa, and they say, okay, there's an ambulance service now, government ambulance service. Can you be available from 3 p.m. to 9 p.m. and we'll give you a token? Yes, be available. If you are off, you are free. Choose the days you can work. This is how people work multiple jobs. Volunteer at certain times. But again, this won't happen if our government does not upscale this. And then we need to strengthen pre-hospital care system. Don't just have ambulance services. I met an ambulance owner, somebody who is starting ambulance services in Abuja here, and I was very proud of him. I was like, boss, I'm happy to work with you. I'm happy to collaborate with you. I'm happy to work beside you and push this through and through. And I was sharing, I said, when you have ambulances, make sure that you're able to identify what kind of emergency the patient who is triggering the call on the app has, and so that you can know what kind of ambulance to send. There are medical emergency ambulances. There's also rapid response teams. So the priority, the kind of ambulance is dependent on the priority of treatment that that patient needs, right? We need to invest more in emergency response. With our equipment, our devices, we need to train more. We need to train more. So I'm also saying thank you again to EHA Academy. Thank you, thank you, thank you, thank you, thank you, thank you, thank you. Thank you for this. Policy reforms all the way from policy makers, from that table. Let's encourage public-private partnership. Look, everyone who is in the emergency space, come out. Let's work with the government. Let's see how we can improve our numbers in this part of the world. Collaborations, all the NGOs out there. I'm calling everyone, global partners. I'm calling, can we change the narrative? Can we change this narrative? We're improving in some parts here, but are we improving in our medical care, especially with emergencies? Some people say, what will we do? They have to carry their person. I said there was a woman, a teacher. I went to school to teach children handlers, and this woman started crying while I was teaching, and then I had to stop and I say, Mama, is everything okay? She said, if only I knew how to do CPR. I said, what happened? She said she lost her husband about a year ago, before that time, and that she used to see in movies where they say, stay with me. So you'll be talking to the ear of the person and say, stay with me, stay with me. She thought that's what you should do to somebody who is sleeping away from you. She kept shouting to her husband, stay with me, or stay with me, into the ear. If only she knew what she could do at that back seat where she was sitting with her husband, simple CPR, it will have increased. I'm not saying it will have brought the man back, but I'm saying it will have increased that man's chances of survival. I had to stop that class temporarily to help us stay comfortable before we moved on. Where am I going? We need to train. We need to know this, and we need to share this knowledge. Don't look at it and say, I'm the nurse, say I know how to do CPR. Hello? If you are the one that now needs CPR, please, who helps you? My kids do CPR. They know how to do CPR. I make sure that everybody around me knows how to do CPR. In case I need it, you should be able to help me. What's the point of having the knowledge and then everybody around me is not useful to me in my own time of need? I'm throwing out that challenge again. Teach people around you. Those of us that know how to do CPR, all the emergency experts, all the 10, 9, 8, 7, 6, and 5 confidence level people, colleagues in this room today. Use pillow. Teach somebody how to do CPR. Don't say, I need mannequin. No, you don't need mannequin. Use pillow, then buy balloon. Teach them how to breathe. That energy required to blow a balloon is the energy required to blow, to release, to ventilate a patient who needs CPR. Is that okay? We can do this if we make up our minds to do it. Right. I'm asking everyone, please, let's do this. There's a National Health Act, 2014 National Health Act, that is Section 20 in that Health Act that says that all Nigerians have a right to emergency medical treatment. How many of us have come across that act before? Every Nigerian, since 2014, this act has been in place. Every Nigerian has a right to emergency medical treatment, and no healthcare provider should refuse to give emergency treatment. Before now, they say, hey, bring police report, the gunshot wound, gunshot this, gunshot that. No. Any refusal is punishable by law, either by the fine or with imprisonment. Recently, I saw the input of the figures, 100,000 fine or 6 months imprisonment. What does this mean for me and you? Anybody who comes in an emergency has a right to be treated. It's okay to say that me too, by virtue of the acts and policies that that our profession is laid on, I have a right to say whether I want to treat a patient or not. Right. But I am saying that every Nigerian is entitled to care. What happens when they now come to you, you need to treat and you don't know what to do? We need to learn. Everybody, treatment, we must be able to give medical treatment, emergency treatment to every patient in need of this service. Say yes? So we must learn. Everybody, we must learn. What's the call to action now? Invest in training, advocate for better emergency equipment. At Care Corps, where I belong, we are quick to ensure that everyone who comes around our way is trained. Every life matters to us. Every second counts. In UK, in Royal Shrewsbury Hospital, a patient came back to say thank you to a nurse. Why? She said that nurse was the one who attended to her. And in that time where she didn't know anything about herself, that nurse intervened. Much later, they came and briefed her on all that happened. And she came back after she recovered, came back and said, thank you to the team that took care of her, especially the nurse who started life-saving interventions. This could be you. Your patients can come back and say, thank you for helping me. I need us to know what to do at every time that it matters. Is that okay, everyone? I need us to know what to do at every time that it matters. At this point, I would want to quickly show you something before I hand over to my moderator. I know my time is fast spent, but let's do a quick. Okay, I would like to stop sharing my screen here. Nice. So let's do a quick, I'd like you to see, okay. I'd like you to see CPR. So I'm just going to demonstrate very quickly. All right. I know. Yes. Maybe that at home. If you okay, everyone. So I'm hoping that you can see me here. Nice. So I want to, my scene is safe. I've assessed that my scene is safe. Right. And I have mannequin here and I want to demonstrate CPR. There's a positioning that makes CPR correct for you. Is that okay? There's a positioning that makes CPR correct for you. You have to learn to kneel beside your patient. Okay, kneel beside your patient and then place your hands in the mid-center. So the middle of the chest. You have to use the nipple as your guide, the nipple line as your guide. So you're staying mid-sternum and you're making your elbows completely straight. So you need to straighten out this elbow all the way. Make sure that your shoulder is at par with this patient's head. If I have to put a ruler between my shoulder and this patient's head, I should be able to get a straight line, okay? Place your hands in the middle of this chest and compression rate is at 100 to 120 beats per minute, but your position is also correct. If you stay here and you are bending and you're compressing, you're not going to be able to effectively compress this patient. And this patient has to be on a firm, flat surface, flattened out completely. So positioning needs to be correct. 30 compressions at a depth of about 5 centimeters, which is equal to 2 inches in the adult. Is that okay? That protocol changes if it's an infant. With an infant, you're going to be using 2 fingers as your hand placement and at a depth of about 4 centimeters, which is 1.5 inches. But let's focus on the adult. So 30 compressions, and I'm going 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. And then I need to open the airway. Remember the head tilt I talked about? Put your hand on the forehead, push it backward, lift the chin up, and breathe. That breath has to be energetic enough to give you chest rise, but that's all you need. All we want is chest rise. Enough to give chest rise. Once you have chest rise, then you get back. What's the other feature I said? Make sure that you limit compressions to less than 10 seconds. Okay, so I'm giving 2 breaths and then I'm back to continue my compressions. The AED, like I mentioned before, is a device that can help to send shock to the heart. With the use of the AED, there are principles of use. As soon as you bring it back, bring it to the scene, turn it on. When you turn it on, the AED is able to speak to you. He's not seeing you, but the AED can speak to you. Is that okay? The AED is able to tell you, guide you on what to do. And it has a sensor that makes it know that you have done what it needs you to do. Okay, it says face the part of the patient's bed chest, face the part. The moment you do that, it has a sensor that says the part is placed, and then it says, do not touch patient analyzing heart rhythm. So the AED, the automated external defibrillator, can help you identify cardiac rhythms. The manual defibrillator, you will, with the ECG rather, you will be the one to have to identify what breathing you are seeing and determine whether this patient needs a shock or not. Exactly. So for the AED, rule number 1, turn it on. Rule number 2, follow the instructions. Yes, you want to place the part. Yes, you want to arrange it. Yes, you want to follow the instruction. Whatever it says you should do, keep doing it. It will guide you because it can sense when you have done what you need and then move it to the next step. When it's time to shock, make sure you clear. Make sure no other team member is touching this patient. Is this clear? Make sure no other team member is touching, not even yourself, not even the person who is giving breath to this patient should touch the patient. And then you press the shock button, you find some, as soon as you deliver that shock, there's some muscular contraction that happens on this patient's anterior chest wall, and then you must get back to doing CPR once the shock is delivered. So that's how to use the AED. There are a few considerations to these of AED, but I'm sure we can have another opportunity to talk about it some other time. So that's what we do with CPR, make sure the position is correct. For the infants, place them on the firm flat surface, but I prefer to elevate the infants higher instead of doing that on the floor. And we are doing 2 fingers or 2 thumb encircling. This is what's called the 2 thumb encircling. You put 2 fingers, your 2 hands around the baby, put your thumb in the middle of the chest, and then you compress. I'm not sure if all of you can see me from there. Then you compress that chest, and you give 30 compressions and 2 breaths if you're alone. The moment you become multiple respirers with the BLS protocol, me and somebody else, or me and other people, that protocol will change from 30 compressions to 2 breaths to change to 15 compressions to 2 breaths. Why are we changing? Because children have more respiratory arrest than they have cardiac arrest. All right. So I think that does it for us. Would like to hand over to my moderators at this moment. Thank you very much for your time, everyone. Thank you for listening.
Oh my God, I think we have gotten so much for giving so little. Those of us that have joined, you are going to give us balance, so because the knowledge that has been shared here is too massive. You know, I am speechless. I know what you can do, and this is just like a tip of the iceberg from where all this knowledge is coming from. We appreciate you so, so much. I want to thank each and every one of us for participating in this webinar. Especially Mrs. Modupe, I want to express our heartfelt appreciation to you. Thank you so much for sharing from your wealth of knowledge. We had a very impactful webinar. I think this is one of the best that we've had so far. So, due to time, I will not be able to summarize all that we have done today, but the knowledge that was shared today underscores the incredible impact that skilled nursing care has in emergency and critical settings. So it is clear that with continued innovation, collaboration, and dedication to best practices, we can further elevate the quality of care and improve patient outcomes. You know, that's the most important thing, to improve patient outcomes. So I encourage everyone to take the insights gained today back to your respective roles and continue to inspire change in the way we approach emergency and critical care nursing. Thank you once again for your participation, and then we look forward to connecting with you in future sessions. There was no question dropped. So I don't think we have any question to attend to, and more so that our time is fast spent. Thank you so much, Ma, for this impactful webinar. Really appreciate you. And be sure that very soon we're going to invite you back, because you just started something and you must finish it. You must finish it. So in the clinic here, a lot of people were saying, wow, 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 I love this woman. I love this one. I said, okay, do you want her to come back again? They said, yes. Okay. So you're going to come back very soon. So you're part of EHA Clinics Academy now. So
Thank you for
just
having
put
me.
that
Thank
down.
you.
Thank you so much, ma. Obina, anything?
Well, should I say I'm short of words, sincerely. This is phenomenal. Thank you, Modupe. It's such simplicity and humility, yet so much knowledge. Yes, I said it in a small way that we're likely to do many things together, but I'm convinced that we should do stuff together. I think in fact, everybody needs to hear you, because I was glad that you were talking about CPR and how everybody should learn about it. You know, it was earlier this year that a colleague was like, we've always been organizing CPR trainings for the medical professional because it is required for our facility for one accreditation or the other. But then what about the non-medical professionals? Because truly we see in the movies where somebody falls down in a mall and somebody who is not necessarily a medic responds, right? And then you brought it home when you even said we could use a pillow, to begin to practice. So I think that all of us should be, should put our hands on deck to see how we can learn this and then share with everybody around. Because you said something also very phenomenal when you said, what if I have all this knowledge and then everybody around me doesn't know it? If I'm the one who needs the care, the intervention, what happens? Because at that time, I can't administer the care to myself. But if everyone around me knows a little bit of it, at least maybe just something, could be different. So I think that our participants this evening must have been blown away. In fact, I knew somebody who told me this evening, I don't like webinars because I don't get a lot from webinars. Okay, I'm going to ask that person after this webinar. Did you really not don't like webinars? Did you really not get something from this? So thank you. In fact, um, uh, I'm short of words, but we're really indeed impressed. Thank you, Nurse Gloria, because I don't know where you fished that out, but this is a
From
big
my
fish.
from my archives.
This is a big fish. So thank you, Madam Modupe. There are no words to really expatiate to capture all that you've done today, right? And a good thing, when we were advertising, at some point, we changed it from being just nurses to healthcare professionals, right? But so we will use what we've gotten here to really market it and see how we can put up something again together so that you would, you could conscientize us, because some of us are just maybe a bit casual about what we already know and all that. And then some people can refresh what they know. So thank you so much. This is time well spent. You didn't overuse our time. It is time well spent, properly used. Thank you so much. Thank you so much. Thank you, everyone,
I
also
didn't even know
for.
that so much time.
Yeah, she made us lose touch of time.
All right, sorry. Let me quickly. Yes, let me quickly take this comment from Gift Chuku. Say thank you so much, Ma. I am truly grateful. Even though I am a medical laboratory scientist by profession, I found the training remarkably insightful and engaging. I believe we should have this kind of training again. It was indeed very interesting and enriching. Although it was a bit too fast, probably because of the timing involved. We should have it again. I agree with you. Yes.
All right. So, Gloria, I think we can close the meeting. Thank you very much, Madam Modupe.
Thank
Maybe you
you.
have one last
I
words. I know you'd have some final
I
words to
need
close the
to
meeting.
thank you. Thank you. Thanks to everyone who considered it worth their time to sit in this webinar today. I do not take it for granted. And again, I want to appreciate the entire learning team at EHA. Thank you, everyone, for putting this together. Thank you. I have two winners. Jonas, Gloria, you'll tell me how to send my gift across to my winners. I hope you documented it. It was
Yes.
what's the name?
Okay, so yeah, it was Onyedikachi, and then I think the second one you called another name, but the first person who responded correctly was Elijah.
Elijah. Oh, I missed that.
Yes, you
And
missed that. So
ew.
he was the first person to respond before you make my Oga stack me. Now my Oga in view. So
No, this is an EHA member. No, what's my own people?
I agree. I agree.
The participants that I owe the gift. So if it's Elijah that is in our room, thank you for banking with us. Please let's spend.
Right.
All right. I want the gift to go to the participants. And I want to say thank you very much, everyone. It's been
thank
beautiful time.
you. Thank you so much, ma'am.
Please don't forget to upscale your skill. Don't forget to be the best version of who you are. That you have the certificate that says that you're a nurse. You can be better than being just the regular nurse on the field or on the block. Thank you, everyone, and God bless you all. Thank you for having me. Thank you, Mrs. Simon. Thank you,
Thank you
nurse.
so much, ma'am. Thank you, everyone. See you next time. Bye.
Bye.